Intratunnel Phacofracture is a nucleus management technique of the manual small incision cataract surgery, in which the lens nucleus is broken inside a sclerocorneal tunnel and removed. Intratunnel Phacofracture can easily performed in all types of cataracts through all sizes of the pupils. Intratunnel Phacofracture can be performed through an incision of 4 mm to 8 mm. In this video we are going to showcase 4 mm intratunnel Phacofracture manual small incision cataract surgery. A 5 mm pharynx-based conjunctival flap is made in the suprarenasal quadrant. Careful dissection of the tenon's capsule is done. Light wet field cautery is done. A 4 mm partial thickness scleral incision 1.5 mm from the limbus is made by a 15-number barred Parker blade. A funnel-shaped sclerocorneal tunnel incision is created with a steel crescent knife. One side port incision is made 90 degrees apart from the scleral tunnel with a 15-degree knife temporally in right eye and nasally in left eye. With a 2.8 mm keratotome, the anterior chamber is entered 1.5 mm into the clear cornea. The viscoelastix is injected into anterior chamber. The capsular hexus is made with help of 26 gauze needle capsulodome from the side port. If glow is poor, then capsule should be stained with trypan blue dye under the air bubble. Then viscoelastix is injected and dye air pushed out. The size of capsular hexus depends on the size of the nucleus. It may vary from 5.5 mm to 7.5 mm. If large nucleus size is anticipated, then 2 relaxing incisions are made at the margins of the capsular hexus. Capsular hexus can also be made by capsular hexus forceps. If capsular hexus is not possible, then cane opener capsulotomy can be done. The internal incision of the tunnel is enlarged sideways to 5 mm by the 2.8 mm keratotome. Hydrodissection is done. An anterior chamber is formed again with viscoelastix and the nucleus is rotated within the capsule using a Singh hook. The nucleus is prolapsed into anterior chamber using a Singh hook. Enough viscoelastix is placed between the cornea and superior surface of the nucleus and between the inferior surface of the nucleus and iris. The eye globe is stabilized with tooth forceps and the vectus is introduced through the tunnel and positioned between the iris and the nucleus. The nucleus is engaged in the lens loop and slowly withdrawn from the anterior chamber while the posterior lip of the tunnel is depressed. The lens, by viscoelastix, the engaged part of the nucleus is pushed back into the anterior chamber and rotated so its longitudinal axis was coincided with longitudinal axis of the tunnel. The remaining part of the nucleus is engaged in the vectus and slowly taken out while the posterior lip of the tunnel was depressed. The remaining cortical matter cleanup is done with direct 23-gauge Simcoe irrigating aspirating cannula. Aspiration should be done from the side port only as anterior chamber remains deep. The anterior chamber is formed with viscoelastix. A single-piece hydrophilic foldable intraocular lens is implanted into the capsular bag. Remaining visco is washed out from the anterior, posterior chambers and capsular bag. Viscoelastix also washed from behind the IOL meticulously. Port sealed by hydration. Conjunctival flap is reposited. First post-operative day cornea was bright clear and vision was 6/12 unaided, corrected to 6/9. Patient could not get 6/6 due to unhealthy macula. "4 mm intratunnel Phacofracture is the simple, safe, effective, economical and reproducible mode of the suture-less cataract surgery. It has all the advantages of phaco surgery.
Intratunnel Phacofracture manual small incision cataract surgery is the savior in certain conditions like non-intact capsular hexis, hard nuclear cataracts, non-getting dilated pupils, poor zonular support and sudden phaco machine breaks down.